All right, so now we're going over the next rhythm. Hopefully, if you just finished the last video, you thought about what this one could be based off the list I gave that first video. But if not, it's okay. So this is supraventricular tachycardia, right? And I'm just telling y'all because again, it's in the video name now, so it's pretty obvious. So not super, but supraventricular tachycardia. So it's very similar to ventricular tachycardia or VTAC. It's another way you'll hear people say ventricular tachycardia. But you'll notice the difference. So a couple differences. First off, these QRS links, they're normal, right? They're looking like normal. In terms of the width, I mean, they have this that kind of looks like, well, it could be a P wave, it could be a T wave. Depending on the person, depending on like what's happening in supraventricular tachycardia, they can sometimes have a P and a T wave, but they're kind of like merged together. Sometimes they don't have atrial contractions at all. What's happening? So in the name supraventricular tachycardia, what that means is that the beat is originating not in the ventricles, but at a point above the ventricles, but not in the sinoatrial node, right? So that's why you're seeing this. You're having like what could be normal QRS, right? But then, yeah, you're not seeing like a P wave. It's still extremely fast, right? It's way too fast. So you're still not getting good perfusion. It's not good. It's still not good, right? So it's very dangerous. It's very lethal. We don't want this. But it is different than ventricular tachycardia. This is what it looks like. So again, as I already said, the electrical signal is originating above the ventricles, right? And again, I have it here in the PowerPoint, but it depends. Like there's different types of SVT, or again, SVT is just supraventricular tachycardia, depending on where above the ventricles it's coming from. So there's a lot of different situations and conditions that can cause it. They all might look a little bit different. They all have maybe slightly different presentations and stuff. And again, there's a lot of different conditions and things that might cause it. So they're all going to look slightly different based off of where it's coming from, right? So what's most important is, well, what do we do if somebody has this, right? Well, there's a few things. So the first one is if the patient's conscious and they're still talking to you, because a lot of times they are, you want them to do what's called a Valsalva maneuver. So some of y'all might be familiar with what a Valsalva maneuver is, but if not, I'm going to explain it. Valsalva maneuver is basically where you're bearing down really, really hard. And the idea here is that it's going to kind of hopefully force the heart rhythm to stop and like reset itself, right? When people talk about performing a Valsalva maneuver, sometimes you'll hear people talk about, well, I was sitting on the commode and I strained really hard and I passed out. Like you'll hear sometimes patients or people might maybe have had to go to the hospital for that. What they've done is they've actually caused themselves to have a Valsalva maneuver and they caused themselves to pass out because they performed one accidentally on themselves because they were like sitting on the toilet and they were straining all the time, which is also why we don't want people to be straining on the toilet because you can actually cause yourself to pass out or perform a Valsalva maneuver. So with our patients, what we want them to do is we want them to say like, okay, cough, cough really, really hard. It's not really going to be the best way to do it, but if you have them like make really forceful coughs, it can. You can tell them to bear down. So like tell them, like imagine you're like trying to blow air out of your mouth, but your mouth is closed, like you're just gonna super hard. Or tell them like imagine you have to go to the bathroom really bad and you're just like really forcing it out. In the hospital, which again, most of y'all are probably gonna end up working in the hospital. Maybe not, but a lot of y'all will. If you have one, which you should, you can get a syringe, right? And you can ask them to put a syringe in their mouth and ask them to blow so that you push the plunger out, right? So in other words, like here's a syringe. This is one that my son uses for his gripe water. So like you ask them to take it and just go. And obviously, like you tell them to do that, and you're not going to be able to force the plunger out. But you're trying to tell them, like, imagine you're trying to force this out that way. The reason that can be useful isn't like it's not better or worse than any other method. But the reason sometimes that's a good method to use is if you just tell somebody like bear down really hard, they might not really understand what you're saying. But with the syringe, you put it in their mouth and it's like a lot more concrete to them. Like, okay, I just like I'm trying to blow the plunger out of the back of the syringe, right? That's yeah, it gives them like a almost like a goal to reach towards or something. So that's kind of the way that we do it a lot of times in the hospital. It's probably the best way to do it. Again, not saying that's the way you have to do it, but it's your patients aren't always going to understand what's going on. Yeah, how they don't know necessarily what a Valsalva maneuver is. They might not understand why you're having them bear down. They might not understand why you're having them blow into a syringe either. But again, it's a lot clearer to them. It's going to make a little bit more sense than maybe just on bear down. They're like, well, what do you mean by that? I don't know what you mean. In terms of meds, so again, calcium channel blockers, beta blockers. These are similar to like ventricular tachycardia. One difference here is adenosine. So adenosine is a med that, again, hopefully y'all all have learned a little bit about, maybe in like pharmacology, maybe not a ton. But the whole idea with it, so I put it in stars, or starred it or highlighted it kind of, is it's a specific anti-arrhythmic, right? And it's used primarily to treat supraventricular tachycardia. It's used to treat some other arrhythmias as well. But adenosine is a little bit special, because what happens is when we give adenosine is it's actually going to stop their heart, right? So we give this IV usually, in a situation like this, we give it IV or something, and it's actually going to cause their heart to stop for a moment, for a few seconds. And you're going to be monitoring to see that their heart starts back, and that hopefully when it stops and starts back, it starts in a healthy, good rhythm. So yeah, it's kind of a high risk, high reward medication. I've heard nurses say that, like, oh yeah, we give the adenosine, but you hold your breath because you're waiting to see, like, okay, is the person better or are they now in a systole? And you kind of start doing CPR and whatever else. So yeah, there's a lot of care you got to have when you're giving adenosine. You don't want to just give it willy-nilly. I can't imagine that you would anyway, but yeah, it's kind of special in terms of antiarrhythmics. And then catheter ablation, as I mentioned in another video, yeah, it's again same as a lot of the other arrhythmias we're talking about. So this is going to be the next one. So again, if you want to take a moment, look at it, have that list in that first video or in the PowerPoint slide that you have. It's got, yeah, the multiple choices, I guess you could choose from. But yeah, take a look at this. What's wrong with it? When I ask y'all, like, hey, what does this look like? What do you think it is? It's not because I necessarily think you're going to know the answer, but more like trying to just think about, like, what is this? What looks wrong about it, even if I haven't gone over it yet as your instructor? Like, hey, what does this look like? What does this look like is wrong? And then we'll talk about it, and hopefully some of your initial hunches kind of play out, and it'll kind of help train you to do the thing that we really want you to be doing, which is critically thinking, right? Because when you get on the NCLEX, there's going to be questions that you're going to look at them and you're like, I do not know the answer to this. And you'll probably even get questions that are going to be about a medicine. And you'll be like, you know what? They never taught me about this medicine in nursing school. And if you were to come out to me afterwards, I'd be like, you're right. I never taught you about that. That's not in any of our lectures, because we can only cover so much, and the NCLEX can ask just about anything, right? So what we want to do is we want to train you to be able to identify, yeah, things sometimes that you're not familiar with, and use, I don't want to say educated guesses, but use what you know to inform your decision making, right? Because it's not just about studying for the NCLEX, right? It's also about being a competent nurse. And depending on where you work, you're going to be in situations where you're not going to know what to do. You're going to be in situations that I've never seen and none of your instructors have ever seen. And you're going to be like, we didn't go over this in nursing school. And you'll look to the physician for guidance. And the physician's like, I was going to ask you what we should do because I have no clue either. I've been in those situations myself. And yeah, you just kind of have to work through it sometimes. So I'm not saying that's the norm, but yeah, depending on where you work, especially locally, we have, yeah, UF Health, which is, a level 1 trauma center. It's a research hospital. That's where I worked, and yeah, you have a lot of unique situations. So anyway, I'll get off my soapbox about that, but that's kind of more why I'm asking you to do this, is just kind of help train you to be trying to think things through on your own without just being given the answer first. So yeah, I'll see you in the next video.